Assalamualaikum and salam sejahtera. So this lecture is about rheumatoid arthritis. So the learning objectives are to describe the pathophysiology of rheumatoid arthritis, describe the clinical presentations of RA, the risk factors, principle of treatment for RA, and also what are the treatment options available for RA. So rheumatoid arthritis can occur because of the release of inflammatory mediators inside our body, and it will attack the joints of the hands. So it can cause like swelling or pain in that affected area, and normally it will start with the hands. Okay. So the inflammatory cells involved include T cells, B cells, macrophage, and plasma cell. So it will attack our body. Will attack the joints in the hands in terms of the release of these inflammatory markers. So that's why the place will be inflamed, and it will cause this the swelling and the pain. So in the end, it can also result in the destruction of the bone and cartilage of that joint. So approximately 1% of the population is affected by rheumatoid arthritis. So it's not that prevalent as compared to the osteoarthritis. So osteoarthritis is also uh, one of the disease in arthritis. So we will see later what is the difference between osteoarthritis and rheumatoid arthritis. So nearly 5% of women and 3% of men over the age of 65 are affected by this disease. So uh, it's a more dominantly affected and elderly, okay, elderly population. So the cause of rheumatoid arthritis is unclear for now. It can be hormonal. It can also be caused by uh, genetic predisposition, and also environmental factors. And for example, the genetic, this gene HLA-DR4 is associated with the increased risk of getting RA, and also cigarette smoking can also increase the risk to get RA. So the picture here shows the difference between normal joints with the joints of osteoarthritis, and also patients with rheumatoid arthritis. So as we can see in the normal joint, there is a synovial fluid, and also there is a gap between each bones, and each bone has their own cartilage to prevent the the friction between the two bones. In osteoarthritic patients, the cartilage is eroded, so the bones tend to rub between each other. Okay, and this eroded cartilage may be associated with aging, or the risk factor might also include injury to the area, repetitive stress on the joint, and can also be because of the family factors, family history of osteoarthritis. So it's more of like a wear and tear condition. Meanwhile, in rheumatoid arthritis, the cartilage is there. Is that there is an inflammation in the synovial fluid in the whole joint area. So it can also be caused by bone erosion. It can also cause bone erosion um, because of that swelling and inflammation. And this inflammation occurs as response to the immune system. So the patient have a um, have their own immune system attacking their own joints. So that's why it is one of the autoimmune disorders. So this is also the comparison between osteoarthritis, psoriatic arthritis, and rheumatoid arthritis. And you can see here the target sites are a bit different. Might also be overlap between osteoarthritis and rheumatoid arthritis, in which rheumatoid arthritis can occur on the wrist as well, as as compared to osteoarthritis is more on the fingers, the joint of the fingers. So the clinical presentation of rheumatoid arthritis is mainly the swelling of the affected area. For example, the fingers, the patients can have a swollen finger, especially on the joints, and decreased range of motion. And some common complaints may include pain, because the swelling is most commonly associated with the pain in the area, the warmth and stiffness of the multiple joints. For example, the patient can wake up in the morning with the stiffness in that joints, and it can last until 45 minutes. Okay, and the peripheral joints of the hands, wrists, and feet are usually involved first. As compared to osteoarthritis, it can also affect the knee, because the knee is usually used very commonly. For the lab findings, uh, we we have to identify the inflammatory markers with C-reactive protein, or ESR, erythrocyte sedimentation rate, and on top of that, further rule out the rheumatoid arthritis, we have to look at the rheumatoid factor and also the CCP, so anti-CCP. So it is an indicative autoimmune disease or marker for rheumatoid arthritis. So these are the criteria of diagnosis of RA. So you can have a look. And the complications of rheumatoid arthritis, it can also be associated with an increased risk of myocardial infarction. Okay, and the way to prevent it is to do annual cardiovascular risk evaluation for these patients, and to use statins to reduce the cardiovascular risk, and also the changes in lifestyle, for example, smoking cessation. And also caution when using NSAIDs, because of the increased risk to have cardiovascular risk, especially with the COX-2 inhibitors. The goal of therapy in RA is to maximize functional status through maintenance or improvement of symptoms. So we want to improve the swelling and improve the joint pain, so that the patient can have a preserved joint function, and to perform their daily activities without any pain and swelling, and to prevent deformity, improve quality of life, and to delay any disability because of RA. So non-pharmacological therapy, we can also suggest the patient to have a plenty of rest, to reduce inflammation, and also to use this kind of splinting of joints, to make sure the patient did not move that much on that area. And also range of motion exercise can also be suggested. For example, the active exercise or passive exercise. Active is when they do it themselves, for example, aerobic, cycling, swimming. Passive is assisted by others. Okay, so the principle of treatment is to check on the baseline parameters. So we need to check on the ESR, C-reactive protein, and also doing a follow-up during 3 to 6 months, and adjust the therapy, because this is a long-term disease, so it will not change much within 1 or 2 days. So the patients need to be counseled on what to expect, and then the compliance to the medication as well, and they have to undergo the follow-up within a few months to see the results of the treatment. So, and also the short-term management of symptomatic pain, so the patient can be given an analgesic to manage the pain. And in patient of DMARD, naive patient, DMARD is the disease-modifying anti-rheumatic drugs. For those patients who do not have not used DMARD before, the non-biological DMARD monotherapy and combination therapy is recommended. This is the treatment algorithm for RA. So we can start with disease-modifying anti-rheumatic drugs, so DMARD. We can use a monotherapy or combination therapy whenever possible. So it depends on the severity and condition of the patient. And we can also combine with the symptomatic relief of the swelling and the pain using glucocorticoid, NSAID, or other analgesics. If this treatment uh, is not working, then we can give the second line treatment, which is anti-TNF agent, and another alternative is rituximab. But there is no other recommendation if all of this treatment is failed. But other available options might include hydrosteroids or any other biological agents. So these are the pharmacological treatment. We can go one by one. So DMARD consists of the example of DMARD is Methotrexate. Okay, so this is the mainstay of rheumatoid arthritis treatment. We want to reduce the joint inflammation, and we want to minimize the loss of joint integrity. So these are the role of therapy. And the newly diagnosed patients should be started with DMARD therapy as a first line, ideally within 3 months of the onset of the disease. So the choice of DMARD depends on the convenience of administration, the monitoring requirement, other medication, monitoring cost, um, the cost of the medication itself, the time to therapeutic onset, frequency and severity of the ADR. Okay, the most prescribed is methotrexate, sulfasalazine, or hydroxychloroquine. So for those who can be given combination therapy, they can be combined with sulfasalazine, methotrexate with sulfasalazine, or methotrexate with hydroxychloroquine, or methotrexate with leflunomide. The onset of action is slow, over 3 to 6 months. However, sulfasalazine, methotrexate, and leflunomide can be beneficial within 1 to 2 months. Okay, so side effect can be serious hepatotoxicity, bone marrow suppression, GI disturbances. So discontinuation or change of drug is usually because of the inefficacy or side effect. So if the patient cannot tolerate the side effect of methotrexate, for example, uh, it has to be discontinued and changed to other treatment. So these are the key points of DMARD. We have to introduce early, like I mentioned before, use combination, use monotherapy where combination is not appropriate, and use cautiously because the side effect can be quite harsh for the patient. So the counseling points, because of the side effect of this agent, we have to counsel patient very properly. We have to counsel them properly and what to expect. Um, and also the dosing, the strength of the tablet, okay, the monitoring, possible side effects, and the combination therapy with analgesics. We can choose simple analgesics like paracetamol to manage the pain, weak opioid analgesics like tramadol or codeine, and also NSAIDs. And for the NSAIDs, it can also cover for the inflammation. Should be reserved for rapid symptomatic relief while awaiting for DMARD onset. So we have to give them together. So DMARD might take a while for it to have an effect for the patient. So while taking an effect, we can cover the inflammation and the pain with the simple analgesics or any analgesics. So the choice can be based on cost, duration, or patient response. For the corticosteroid, the benefit is to is that it can slow the progression of joint damage due to anti-inflammatory effects. So it will reduce the inflammation. It can also be used as a bridge therapy while awaiting response. It's also the same with the analgesics. So it will be used to while awaiting for the response to DMARD. Can be administered orally, for example, prednisolone. But we need to be cautioned that it cannot be used for a long term because it can also cause osteoporosis. And osteoporosis is also one of the complications associated with RA itself. For the biological treatment, it can be used if the patient failed a DMARD, and it can have a fewer monitoring requirements as compared to DMARD. The first time can be rituximab, infliximab, or etanercept, but of course the cost will be higher. So these are the example of biological agents. So all of them is not available orally. Okay, so the patients need to take it either subcutaneous or IV injection. So the patient care, the first we need to encourage the patients to engage actively in their pharmacological and non-pharmacological treatment. We have to advise the patient properly on the importance of compliance, and also non-pharmacological treatment is also uh, might also help the patient in this condition. And encourage patients to take responsibility of their medication and understand the side effects, and remind the patient on the warning symptoms that requires them to seek medical attention, because this is a long-term disease or long-term problem. So the patients need to embrace the condition itself, and they need to understand what are the things that might help them, including the lifestyle changes, or any change in diet, for example. Okay, so that's all for this topic. So this is just a brief introduction. So if there's any question, that you can ask me later. Okay, thank you.